Today is the 12th of January, 2018, the Society of Surgeons has embarked on a program to interview the surgeons who made and shaped surgery in this country. And we are starting off today very happily with Dr. Rupert Indar, Sr., who has been one of those early surgeons who molded the whole surgical scene here in Trinidad and Tobago. Dr. Rupert Indar, Sr. is a general surgeon, and his dates of postgraduate training were on both sides of the Atlantic, and they culminated in 1962 when he became a consultant at San Fernando General Hospital. He has not worked in any other hospital except San Fernando, where he worked for 29 years before retiring. So Dr. Indar is one of the stalwarts of surgery in this country. Dr. Indar, sir, can you tell us your dates of postgraduate training?
Yeah. Well, I graduated in 1952 with the Irish degree MB, CHB, BO. They gave a degree for medicine, surgery, and obstetrics. I also, at the same university, got my Master of Art. At that university, you do an intercalatory degree, which was a BA during your undergraduate period, and after a certain number of years, you can pay a small amount and get an MA. The next step in graduation was the primary fellowship, which was got in 1954, and my London fellowship was got in 1959. In the period that I worked at Trinity College as an assistant lecturer in anatomy, I did research, and with the results of the research and a medical exam, I was awarded the doctorate in medicine degree. Subsequently, I was awarded the fellowship of the American College of Surgeons in 1966.
Dr. Indar, what institute did you train, both in the UK and the USA?
I worked at the Leahy Clinic for 2 years in 61 and 62. And at that facility, they were quite good at hepatobiliary surgery, and there used to be a race from time to time between two surgeons who can do a Whipple's faster. So I had 2 years at the Leahy Clinic, and that ended in 1962 when I was invited to come to Trinidad as a consultant in general surgery. And I did some pediatric surgery at a children's hospital in Finland.
Very good.
As a result of that, they were quite adept at doing surgery for pectus excavatum, and one of my sons had the benefit of such an operation.
Very good. So your appointment as a consultant here in Trinidad in 1962, correct?
Yes.
Right. How many years your postgraduate training ultimately finished in 1954, correct?
The postgraduate training finished in 62.
Okay, but your appointment in Trinidad as a consultant?
Was in 62.
Okay. All right. You mentioned the hospital you worked abroad in the US and the UK. Apart from San Fernando General, where we know you made your mark, did you work in any of the hospitals otherwise in Trinidad?
No other hospitals.
What year did you actually retire from the government service in this country?
In 1989.
1989.
Yeah.
Okay, thank you. So, pass over the other questions to Dr. Gujra, my colleague here, will take it.
Mr. Indar, thanks for being here. You were confirmed as a consultant in 1962. What changes did you bring about in your field of surgery?
I fortunately succeeded a surgeon called Das, who did quite good work, but he was mainly a cardiac person. And so from a general surgeon's point of view, they did work and it was adequate. What was noticeable was the number of patients who had suprapubic drainage for retention as a definitive procedure. And that was the thing that stuck in my mind. And as a result of that, there are about 15 or 18 such men, and I converted them into, did prostatectomies on them. And again, those patients, I did a transrecycle.
Okay. So now, what were the challenges in surgery then?
Then there was orthopedic service, but we did the pediatric surgery too. So we did general and pediatric.
Give us an idea of the surgical demands then.
One of the important things in many categories of people coming back to Trinidad, they don't want to change and accommodate what's available locally. They want to do the same things in Trinidad as they did elsewhere, and that's not always possible. So you had to modify how you did things, compromise at various points, but the bottom line is you got things done for patients.
We know that you all did a lot of surgery with little remuneration. Can you give us an idea of what the salary was?
Well, the salary I'm sure was small. I really can't remember the figure, you know.
Yeah, okay.
But it was small. But the fortunate thing was consultants were permitted to have practice out of hours, and that made up for it, you know. That made up, and I think I respected that, and I worked every day, whether we on or off, to see patients. Again, I did my office and private work separate and apart from the hours which one was expected to work in the service.
How long did you serve as a consultant before retiring?
29 years.
29 years.
29 years. 62 to 89, I think.
Mr. Inar, you supervise and you were mentor to many surgeons during your tenure. Can you give us an estimate of how many doctors passed through you when you were consultant?
I'd say we categorize them into those who did internship and went on into practice, then those who to internship and went on. I'll say about 3 or 4 went on to consultants, and the rest were registrars and went on. Some of them migrated.
Mr. Inar, what state of affairs did you leave the service in? And what are your suggestions to fix these?
Oh, the system was very primitive, and I still think it still exists, because for equipment, you had to do it on an annual basis, and when at the beginning of the year you have made your list, and so you might not get it for 2 or 3 years. Shortages of drugs were notorious, but again, the demand wasn't as large as it is today.
What sort of suggestions do you have in terms of to alleviate these? Because we still have these problems.
Yes, well, I think this is entirely political. Because in the private sector, there's no problem. In fact, this is one of the clear distinctions I made in a document I'm doing, that whatever that was needed in the way of staff, equipment, medications are easily available. And regrettably, agents tend to ignore lower cost medications which are important. The one that sticks out to my mind as a surgeon is potassium supplements for after surgery. So I think this is entirely political, and it's the budget is adequate if it's properly spent.
So now, what recommendations do you have for surgeons in training and in active government practice?
I'd start with that nowadays young doctors and surgeons go straight on to CT and MRI without putting a hand on the abdomen. So they've got to learn to do clinical examination, and in particular abdomen. Once you have a sign in the abdomen that is a physical finding of tenderness and rigidity, it's an important thing. So I think surgeons must learn to examine clinically, come to a clinical diagnosis, and then start your examination.
Mr. Enar, do you believe that a surgeon can be adequately trained in Trinidad?
To some extent, but you will. It's always good to have 1 or 2 years abroad. It's always good to. I was fortunate that I didn't have a time limit for my training. It was just went on.
Mr. Enar, if you could relive life, would you choose surgery? And if yes, why?
Yes, yes, because yes, I would do it again. I would naturally like to learn and attain certain competence in minimally invasive surgery, but the results are good. You know, you help patients, especially patients who are catastrophically ill, and apart from trauma, those with severe infections of the colon, mainly diverticulitis and its complications.
Dr. Enar, we're going to address the state of the art of surgery in your field as it exists in 2017. Could you comment on the present innovations in your field, especially focusing on minimally invasive surgeries, including robotic surgery?
Certainly the minimally invasive surgery is here to stay. It's here to stay, in particularly for gallbladder conditions, non-malignant conditions of the colon, and other things like that. Open surgery is still important. As a matter of fact, for gallbladder surgery, one always have to have the permission to do it open in case it cannot be adequately done. For malignancy, I feel it should always be open so you can get your tissues in continuity. And of course, robotic surgery is progressive, it's accurate, it's flexible, and for certain conditions, in particular in your field, prosthetic surgery is very useful.
Do you think that minimally invasive surgery, including robotic surgery, is a better and or a safer way of performing your type of surgeries? Or do you think open surgeries are superior?
Yes, oh yes, and the training can only be by apprenticeship. Can only be by apprenticeship, And while you have all other systems to qualify as a surgeon, apprenticeship still takes the place, mainly 30-40% of training a surgeon.
Would you care to suggest a timeline for this tutorship or apprenticeship?
Yeah, I'd say minimum 2 years. Minimum 2 years.
You have seen a lot of surgeons come and go. What would you care to comment on your personal observations of young surgeons who have taken over in, say, general surgery? Would you care to comment on your personal observation? Anything that has struck you as good or bad?
Yeah, well, not here, because the people who work here are quite experienced. But I'd say hearing about some of the complications, and some of these complications are because of people who are young and hurried and probably inadequately trained.
Anything particularly pointed or poignant you want to tell these young surgeons who will be listening to this interview? Any message you'd like to give them?
Yeah.
The system they're training?
Importantly, you must be very familiar with the anatomy and the pathology that you're dealing with, and always handle tissues carefully, assess especially malignancy, whether you could deal with it or not, in particular malignancy of the stomach, which is quite rare now, fortunately. So I think they just need to not to rush things and be careful with their surgery.
Were you able, as a consultant, to bring about changes in surgery while you were consultant?
Yeah, well, the changes that have taken place, I thought, were good. For example, you had more subspecialties, and you have people trained in this, especially people who've trained in America with their residency program and completed, and from England with the exit exam for the specialist degree. So all these have changed and improved.
Okay. What sort of challenges did you face as a consultant?
At that time, the challenges were for drugs, for equipment, and staff.
Yeah.
Those were the three main categories of shortages, and one just had to work with them and manage them, manage how you can. But again, I was fortunate in that I was able to get everything I needed, one way or another, to get the work done.
What is your vision of surgery to come in the future?
I would say we will continue to do more and more laparoscopic surgery as it's being done. In fact, some experts virtually do everything laparoscopically. That's a great attainment. So I see that. I see robotic surgery being used more and more in particularly university settings, which has the facilities and the ability to have a robot. So I think these things will go on, but nonetheless, you still have a place for open surgery in certain conditions.
Bisnaro, you're a phenomenal person. There were many fields, you had many fields other than surgery. How did you prepare for retirement?
Yeah. The fields that I have been recognized in is because I like the fields, you know. I like the fields, I enjoyed it. And for example, in the intercalatory degree, you do some economics. And then running a private hospital, I don't like to compare ourselves in private hospital administration to the businessman who imports put a markup and sells. We have to cost things differently. So you have to be, it has to be challenging. And what is fortunate now, computerization has helped a lot in the costing of things. So I think that horse racing, you know, I started it as a boy and still enjoy it. So the things that I've been recognized in and been honored is the thing I enjoyed.
Mr. Nar, can you change the current image of the doctors?
Right. I've said that doctors have a monopoly. And when you have a monopoly, you must not waste it and use it badly. So, further I say that every patient has a brother, sister, mother, and a father. So you must treat those patients as if it were your own relatives. Be well trained. Doesn't matter about money, because if you're any good, you will learn. So these are basic fundamentals, and I think young doctors, and when they get older, a lot of them mature in those different ways, which will be satisfying.
And finally, Mr. Nar, would you advise a young doctor to do surgery?
Any professional, in particular medicine, you must do what you like. If you do what you like, you become good at it.
Mr. Nar, thank you.